Okay, so good evening and welcome to our series of Zoom events at LMU. My name is Christina Bogdanou. I'm the director of the Kalogeras Center for Modern Greek Studies. On behalf of the center and LMU, I would like to welcome Dr. Vassilios Papadopoulos and Dr. Richard Deng, who will talk to us about the COVID-19 vaccines. At the time that we face record numbers of infections here in Los Angeles and around the world, we're thankful to have them talk to us about the latest information on the vaccines. I would also like to thank the Consulate General of Greece in Los Angeles and the Consul General Evgenia Beniatoglou for co-hosting tonight's presentation for our community. Before we start, allow me to introduce our speakers. Dr. Vassilios Papadopoulos is the Dean of the School of Pharmacy at the University of Southern California. He holds a John Stauffer Dean's Chair in Pharmaceutical Sciences and is Professor of Pharmacology and Pharmaceutical Sciences at USC. Dr. Papadopoulos is a graduate of the School of Pharmacy of the University of Athens in Greece. He completed his PhD in Health and Life Science at Université Pierre and Marie Curie in Paris, and his postdoctoral studies in France and Australia. In 1988, he joined Georgetown University School of Medicine, where he rose through the ranks to become professor and chair of the Department of Biochemistry and Molecular Biology, and then director of the Biomedical Graduate Research Organization at Georgetown University Medical Center. In 2007, he moved to Montreal as executive director and chief scientific officer of the Research Institute of the McGill University Health Center, and professor of medicine at McGill University, where he held the Canada Research Chair in Biochemical Pharmacology and Phil Gold Chair in Medicine. Dr. Papadopoulos' research focuses on the physiology and pharmacology of steroid hormone biosynthesis in health and disease. He has published over 350 papers, holds numerous patents, and serves on advisory committees on various US, Canadian, European, and other international agencies, institutions, foundations, and corporations. Dr. Papadopoulos is an elected member of the French National Academies of Pharmacy and Medicine and an elected fellow of the American Association for the Advancement for Science, the American Association of Pharmaceutical Scientists, and the Canadian Academy of Health Sciences. Our second guest is Dr. Richard Deng. Dr. Deng holds a Doctor of Pharmacy degree from the USC School of Pharmacy. He's Assistant Professor of Clinical Pharmacy and Program Director of the PGY1 Community-Based Pharmacy Residency Program at the University of Southern California School of Pharmacy. He is President-elect for the California Pharmacists Association. His expertise in immunizations, travel health, and community health programs has led to his role as a leading advocate during the COVID-19 pandemic. He is chair of the California Pharmacists Association COVID-19 Task Force and is a member of the USC COVID-19 Vaccine Planning Steering Committee, the California State Testing Task Force, the CDPH Immunization Branch Pharmacy Task Force, and the Adult Work Group of the Immunization Action Coalition of Los Angeles. Dr. Deng is also a medical consultant to international travel health and COVID-19 testing and vaccination companies. Well, thank you both for joining us tonight. We're very happy to host you. Dean Papadopoulos, perhaps you would like to go first.
Yeah, thank you. Thank you, Christina, and thank LMU and the Center for inviting us. It's a real pleasure for those who speak Greek, Kalispera. So a real pleasure to really be with you tonight. As always, I say, we have some answers, not many answers, but some, and hopefully we'll be able to answer some of your questions. Richard, Dr. Deng will give you more detail about the vaccination process, what we know about the vaccines, but some things really for us to know that the science behind the vaccines and the science behind the new vaccines, the RNA vaccines, is not today. It is evolution. Science is an evolutionary process, and vaccines originally used to be made by proteins or organisms that were injected in animals and people, create antigens, and this is how we really activate the immune system. And then we moved to the DNA for many, many years, and the DNA forms RNA. And almost 15 to 20 years ago, first time people experimented with injecting RNA and tried to use RNA as a vaccine. RNA is very sensitive, it's destroyed very rapidly, so many failures until people managed to make very stable RNA that encodes for specific proteins, but managed to do it and really deliver it to make first vaccines in animals has been a few years now. Actually, the German company BioNTech and Pfizer, before COVID-19, they had a contract already for 3 years now, developing flu vaccines using exactly the same technology. So when the time came, the infrastructure was there, and they directed the efforts to the RNA. So for Moderna, the history is a little bit the same. So they found RNAs affecting cell functions, they stabilized them, and essentially they were targeting mostly into the cancer area, the original interest rather than the immune system. But also when they saw the advantages, how this could work, they turned their attention to the immune system. So this is why to everybody's surprised, but not people who really work with the industry and in science, how things move so fast. Traditional vaccines take more time to make. This was done very fast because we are talking very specific sequences, the technology to modify, to stabilize already there. And then the delivery technology, you need to protect them. They use like lipids, lipid particles, liposomes, nanoparticles, because this is minute amounts, and you can deliver it, and then you create the immune response. So it took 8 months. Now it takes sometimes more time to produce this in massive amounts, rather than really the whole science behind, since the secrets have been already well understood and unveiled over the last 10 years. So this is the first thing I would like really to clarify. And now again, it is, however, the first time that these now were done in humans. So the trials were very positive. Richard will talk about that. Actually, even more successful than anything we have seen before in the history of vaccines. 95% success is unbelievable. We hoped at 50%. So even 70%, which is a vaccine based on DNA technology, at the AstraZeneca in England, even this 70% is also a great success. So this is pretty much about the history of the vaccine. So during clinical trials, evidently, and you will see some of these results, you have, again, the people where the vaccine is tested, but also the placebo. What you will discover as the concept of placebo, some of you may be surprised, people react to the placebo. And we do this in any clinical trial, and many times you have a placebo effect, which is as important as the medication. Now, it's not the case here, but you could have side effects of the placebo, which is something really to keep in mind. This is as for more information purposes. So I will stop really here, and I will ask Richard, then we can come back to answer questions. Richard, please.
Thank you, Dean Papadopoulos, and thank you, LMU, for the invitation and having me come and speak today. My goal today is just to cover some of the information regarding the COVID-19 vaccine, to update you on some of the clinical data that we are aware of so far, as well as to talk about some of the vaccine allocation and timeline for when you may be able to receive the vaccines. So I do have some slides here that we'll go through. And feel free to ask any questions in the chat box, and we'll address them either along the way or at the end. So I do like to start with some background, just to kind of set the picture of where we're at. I think we all recognize that we are experiencing an unprecedented public health emergency with the COVID-19 pandemic. So needless to say, I think we are aware that we have a problem. But I do just want to put that into context that this is the data as of today, that 87 million cases worldwide of COVID-19 have been confirmed, and 21 million of those coming from the United States. So it is a continued issue of great magnitude. Now, as we look ahead to how we can resolve the pandemic, a lot of the discussion is around vaccinations being one of the important tools in our toolbox to help us fight back against the virus and to bring us back to some sense of normalcy. If you've been keeping up with the news reports over the last 3 weeks, it's been a whirlwind of information. And for me, it feels like a year ago, just living through that constant update. But we do have vaccines now that are available, and here's the latest data as far as the numbers of how many people have received vaccinations. So in the United States, nearly 21.5 million doses of the vaccines have been distributed to the states and local level to administer into individuals. Of that, about 6 million individuals have received the first dose of their vaccine. So far, 6 million people in the United States have received vaccination. Now, specifically in California, California received about 2 million doses that were shipped out to the local regions. And of that, about 580,000 vaccine doses have been administered so far. So as we look at the numbers, they are small, but we are looking to really quickly ramp up those numbers over the next few weeks. As we discuss some of the timeline for when the vaccines became approved, you'll see that they really just came available within the last 2 to 3 weeks. And I do think that some of the holidays hampered the ability to increase our goal of vaccinating as many people as possible. But here we are today with nearly 580,000 individuals having been vaccinated in the state of California. Now let's talk about the vaccine and some of the technology and data that is associated with it. So as Dean Papadopoulos mentioned, there are a variety of different vaccine technology that are currently utilized with our different products that we have. So for example, with the influenza vaccine, typically we use a weakened version of the virus to stimulate your immune system. Or with the hepatitis B vaccine, we use a subunit or components of that particular virus to stimulate your immune system. But when we're talking about the COVID-19 vaccine, we're actually utilizing some new technology, or relatively new technology that Dean Papadopoulos reviewed, and that's the mRNA vaccine. So we're going to be focusing in on some of that information as far as what is mRNA, how does it work, and what is the data associated with that particular vaccine. In order to understand how the mRNA vaccine works, we do need to take a step back and talk about how the virus itself infects cells, right? So as you may know, COVID-19 is caused by the SARS-CoV-2 virus. And so that particular virus has a very unique protein structure located on the surface that helps the body, well, that's helpful because that helps our body identify that particular virus. That particular protein, which we call the spike protein, is also what the virus uses to bind to our cells in our body. So as the virus becomes introduced to our body, it floats around until it comes into contact with a cell that has that receptor. And once it recognizes that receptor, the protein binds to that receptor, and that is what causes the fusion that allows the virus to enter your regular cells. As the virus enters your regular cell, what happens then is that virus starts replicating. So it starts creating copies of itself in your regular cells, and it takes over. So instead of having your cell function normally, so for example, let's talk about a lung cell. So instead of having your lungs function normally, the virus takes over and it uses those lung cells to create copies of itself that it then releases. And then as those viruses get released from that lung cell, it gets distributed and then it attaches to and infects other cells throughout your body. And that is how the virus spreads. And so the key component of that is that spike protein. That is what allows the virus to take over our normal cells and to allow it to replicate. What typically happens when you become infected then is that your immune system tries to fight off the virus. Your immune system immediately recognizes that there's something that is in your body that doesn't belong. It's something that's foreign, that they know should not belong there. And so your immune system creates a bunch of different cells through the immune system. And to simplify it, essentially you have fighter cells that are created that help kill the virus, and memory cells that are created to help remember the virus for future encounters. And so as your immune system is fighting against these viruses, those are the two main cells that are being created that help your immune system function. Now, in some people, their immune system is able to completely get rid of the virus and they survive and they don't have any significant issues. But as we all know, there's a significant amount of deaths associated with COVID-19. And so for those individuals whose immune system is overwhelmed by the virus, those are the people who end up becoming hospitalized, who end up becoming in critical care, or who sadly end up dying because their immune system became so overwhelmed by the virus, there was not nearly enough fighter cells to remove the virus from their body. Now let's talk about how that virus replicates or creates copies. So the key component of that virus is that it does create something called mRNA, which is messenger RNA. And messenger RNA is a translation of your DNA. So the way that we would like to compare it is that the DNA is the blueprint. It contains the code for everything that the virus does. And as Dean Papadopoulos mentioned, the DNA of the SARS-CoV-2 virus was quickly identified in early January. And that was really essential in allowing our scientists to create the vaccines that we have today. So the DNA creates the code that allows the virus to create that protein. And the mRNA is the message that the cells use to create that protein. And so when we're talking about mRNA and the particular vaccine that we have, that vaccine that we're using contains the message that helps create the protein that is unique to the SARS-CoV-2 virus. So that's really what we have with the mRNA vaccine. It's really just the mRNA, which is the message that creates those proteins, and a fat cell. That fat cell then carries the mRNA, which allows it to be delivered into our regular cells. So what's happening here when you receive the mRNA vaccine is the fat cells delivering the message to your cells, and your cells then reads that message and creates that protein that would normally be found on the SARS-CoV-2 virus. And so in this way, your body is able to generate that protein to trigger your immune system to respond to it so that it can create those fighter cells and those memory cells to build your immunity. So what we're doing is introducing that protein that is so important to the SARS-CoV-2 virus without actually introducing you to the virus. And that is how the mRNA vaccines end up working. So that's what the vaccine does. It helps your body create the protein that's unique to the virus. It helps your body learn to recognize those proteins, and it helps your body to react to exposure of that protein in the future. And all of that is done without the virus, is done without infection, and it's done without the disease. And that's really important and really impressive because we're able to train our body to recognize the unique spike protein of that virus. So then when you receive the vaccine, you will develop the memory cells that will recognize that. And in the future, if you are exposed to the virus again, your immune system is able to immediately react to get rid of the virus. And so then it won't become overwhelmed by the number of viruses that you have in your body. So essentially, the vaccine helps you create those memory cells, and those memory cells tell your body to rally the troops to get those fighter cells to kill the virus. And that's how overall that particular vaccine works. Now let's take a look at some of the data as far as how well it works. What we have right now is 2 COVID-19 vaccines that are authorized by the FDA. We have the Pfizer and BioNTech vaccine and the Moderna vaccine. There are a number of others that are in the pipeline that are still being evaluated that have not yet been authorized. So currently we have these 2 vaccine products that are available in the United States. For the review of the data, I am going to primarily focus on Moderna vaccine just to keep it simple for discussion. I didn't want to go over too much data, but for all intents and purposes, the clinical data for Pfizer and Moderna are nearly identical. They have very similar outcomes and results. And so for that, I am just going to focus on one vaccine that will represent both of the products. The COVID-19 vaccines did go through the standard clinical trials that we expect for all vaccine and medication products. So I do like to point that out because no steps have been skipped in the process. Despite it being done at a rapid pace, there were no steps that were skipped. There were phase 1, phase 2, and phase 3 trials that were concluded and conducted for all of the vaccine products. And in specific, this slide summarizes the data for the Moderna vaccine. One of the other reasons we were able to accelerate the timeline for the COVID-19 vaccine was that these phases were allowed to be conducted simultaneously as opposed to sequentially. So what typically happens is that you complete a phase 1 study, which might take a few years, and then you wait and you analyze the data, and then you wait and you collect funding, and then you wait and you plan the phase 2, and that itself takes a few years. And then you start the phase 2, and then that cycle repeats again. But what happened here with the COVID-19 vaccine is they did the phase 1, phase 2, and phase 3 almost at the same time, right after the other. So they took away that gap period of planning and finding funding. And that's one of the other reasons why we were able to accelerate it. So some of the reasons so far for the accelerated timeline included identification of the DNA sequence of the virus in early January, increased federal funding to the companies to focus on vaccine development, and the sequential phases of the clinical trials, the simultaneous phases of the clinical trials as opposed to the sequential trials. The other thing I really like to point out when we discuss the COVID-19 clinical studies is that in the phase 3 trial where they evaluated the efficacy, the safety, and the immunogenicity, there were nearly 30,000 patients who participated in that phase 3 clinical trial. And that's a significant amount of individuals where the product has been studied in. As a comparison, other vaccine products typically have 10 to 15,000 participants in their phase 3 trial. So we're talking about the sheer number of people that this vaccine has been studied in. This already exceeds it. So for Moderna, there were 30,000 people in the phase 3 trial. And with Pfizer, there were 40,000 people in the phase 3 trial. So in total for those two products, there were nearly 70,000 people where the product was evaluated in before it received authorization. And we're not even talking about the other trials for the other vaccine products that are on the market. So when at the end of the day, we might be talking about over 100,000 people where a COVID-19 vaccine has been studied in. And again, that is a huge increase compared to what we typically see with other vaccine approvals. With the COVID-19 vaccine, phase 3 trial for Moderna, they had 30,000 people that they randomized. Half of them received the actual treatment, which was the mRNA vaccine, and the other half received a placebo that was just normal saline or salt water, right? So they randomized people into those two groups, and then from there, they followed them daily and then weekly to see if they had any symptoms of COVID. They tested them, and then they also tracked to see if they had any side effects. So there was a lot of regular follow-up during the phase 3 trial, and every single participant was followed for at least 2 months after receiving the last dose of the vaccine. And so what we see here on the slide is that overall, the vaccine has demonstrated to have a 94.1% efficacy. And as Dean Papadopoulos said, that is a very impressive efficacy value to have demonstrated. Rarely do we see our vaccines having 90+% efficacy. As a comparison, our influenza flu shot vaccine typically has a range of 40 to 70% vaccine efficacy. So to have something that's 94% is really impressive. And the Pfizer vaccine was equally impressive with 95% vaccine efficacy being demonstrated. And these trials did look at different populations to evaluate the efficacy. So they did include individuals that were 18 to 65 with or without health conditions. They did look at individuals 18 to, and they also looked at individuals greater than 65 with or without health conditions. And they also looked at individuals greater than 70. They had a pretty even split of female versus male. They also looked at a variety of different races and ethnicities. So they had participants that were Asian, that were Latino, that were African American, Native American, etc. The Moderna trials also looked at occupational exposure. So they also looked at the vaccine efficacy of firefighters, of doctors, of nurses, to see if the type of jobs that you do, of grocery workers, to see if the type of jobs that you do had a difference on the vaccine efficacy. And essentially what the data shows is that across all of the different groups that they evaluated, they saw a very consistent vaccine efficacy of at least 94, at least greater than 90%. So almost every single subgroup that they analyzed demonstrated that high vaccine efficacy. There was only a few groups that demonstrated a little bit lower, and those were the very elderly individuals. So adults greater than 65 demonstrated a little bit lower vaccine efficacy. So you see on the slide here that the 65 to 70 was 82%. But interestingly, those that were above 70 years had 100% efficacy. Can we really say that all older adults would demonstrate lower efficacy? We're not sure because of that mixed data. But I think the main point is that it is still a highly effective vaccine in every single population that the product was studied in the phase 3 trial. The other thing I like to point out on this slide is that the vaccine efficacy refers to the ability of the vaccine to prevent confirmed symptomatic COVID-19 disease. So it didn't study whether you could spread it to other people. They didn't study how it reduced the infectiousness of the virus. They didn't study whether it prevented asymptomatic disease, but they did study if it prevented symptomatic COVID-19. And that's an important marker because typically you don't become hospitalized or you don't die unless you have symptoms. And so this is really looking at those very severe cases. And so we know that the vaccine is highly effective in preventing symptomatic disease, highly effective in terms of preventing death, and highly effective in terms of preventing hospitalizations. This other chart just really summarizes the data of that vaccine efficacy. And what I'll point out is that top line that goes up, that is the placebo group. And what this chart is showing is the number of cases of COVID-19 in the study populations. So you'll notice that over time, that black line for the placebo group is increasing, which means that a lot of people in the placebo group ended up getting COVID-19. But the bottom line, which is the blue line, that's the treatment line. That's the people who receive the mRNA. You can see that over time, the treatment group is pretty steady. It's almost flat. So that also demonstrates the vaccine efficacy of that particular product. You can see the huge difference of the number of people in the placebo group versus the treatment group who ended up with COVID-19 over a long period of time. Now let's look at the safety data. Overall, the vaccine has been demonstrated to be very safe. So this slide here summarizes some of the main side effects that we saw in the trials for the Moderna vaccine, and the Pfizer vaccine, again, is very similar. As you look at the information here on the slide, you see pain at the injection site, potential swelling or redness at the injection site, some fatigue, some headache, some nausea and vomiting, etc. All of these side effects are what we would expect with any other vaccine. So for me, that was very encouraging because there were no unexpected side effects from this product. There were no rare or significant side effects from this product. And everything that we see as a side effect is what we would see with any other vaccine. Same with the flu shots, same with the tetanus vaccine, same with the shingles vaccine, same with the pneumonia vaccine. These are very similar side effect profiles. As we take a deeper dive at the clinical data for the side effects, these are some of the exact rates. And what you'll notice here is that on the left side, you have the younger adults, and on the right side, you have the older adults. So generally what we saw in the data actually was that younger adults were the ones that experienced more side effects than the older adults. And the other information that you see on here was that you see a lot of the color green. Green defines grade 1 side effects, which means they're very mild. Red would be very severe side effects. So as we look at this slide, even people who experience side effects, whether it was pain or redness, the vast majority of those individuals were mild symptoms. So the vast majority of this chart was green. And this is the data of the side effects after the first dose. And this is the data of the side effects after the second dose. Now, the other interesting thing to note was that there were more moderate side effects reported after the second dose of the vaccine. So now we know two things. One, well, we know three things. The side effect profile is as expected. Two, younger adults typically experience more side effects than older adults. And three, you typically experience more moderate type side effects after the second dose. And as we look at the types of side effects you experience, as I mentioned, these are what you would normally expect with any vaccine, but this is also a sign that your immune system is working. You want to have these side effects because that means your immune system is working. Because essentially what we're doing is we're tricking your body to think that it's been infected, right? When it recognizes that spike protein, your body goes into high alert and says, the virus is here, we need to fight it. And so when you have those fevers, when you have that swelling, that redness, that is a sign that your body is generating those fighter and memory cells to help you build long-term immunity. So the bottom line of the data that we have so far is that it has been studied, it has gone through clinical trials, it is demonstrated to be safe, it is demonstrated to be effective, and it has a very typical side effect profile. Having said all that, there are some unknowns, right? Like I mentioned, we only studied it in terms of preventing symptomatic disease. We don't know how good the vaccine is in terms of preventing its spread to other people. We don't know how well it prevents asymptomatic disease. All of that is still information that we still have to find. We also don't know how long the vaccine will give you protection for, right? So the longer we study the vaccine, the more information we will know about how long the protection lasts. We don't know if it's something that's going to be like the flu shot where you have to get it every year, or if it's something like the shingles vaccine where once you get it, it's good for long term. So having looked at all of that data, the FDA and the CDC and other independent scientific groups evaluate the data to decide whether or not to authorize the product to be used in the United States. So I'm going to summarize some of that information. So specifically for the Pfizer vaccine, the FDA reviewed the data on December 11th and recommended its authorization. Then from there, on December 13th, the CDC reviewed the data and recommended its use in the United States. And additionally, in California, Governor Newsom created an additional layer of approval before the vaccine could be used in California. And that is the Western States Scientific Review Work Group, which included California, Nevada, Washington, and Oregon. So scientific experts from all of those states also reviewed the data on December 13th and recommended its use in their respective states. So overall, the Pfizer vaccine was authorized for the use of prevention of COVID-19 in individuals 16 years and older. And that's because the trial, the studies only included patients 16 years and older. They are currently studying younger children in the study, but those data is not yet available. So as that trial, including the adolescent groups, concludes, the FDA, CDC, and California groups will then review the data at that time and revise the authorization if it is appropriate. But at this point in time, Pfizer is only approved for 16 years and older. Moderna followed a very similar timeline. Moderna was 1 week after. So Moderna was reviewed by the FDA on December 17th. It was reviewed by the CDC on December 18th and 19th. And it was reviewed by the California Western States Group on December 20th. And all groups recommended its use and authorization. So the Moderna vaccine was authorized for use in 18 years and older for similar reasons, because the trial and the finalized data only included individuals 18 years and above. Again, the adolescent studies are ongoing, And as that final data is released, the authorizations can be revised if it's been shown to be safe and effective in that population. Some other key information to be aware of is that the vaccines are not interchangeable. So what that means is that when you receive your second dose of the vaccine, it has to be the same product. So both of these vaccines are 2 doses. And if you start with the Pfizer vaccine, you have to complete it with the Pfizer vaccine. If you start with the Moderna vaccine, you have to complete it with the Moderna vaccine. You can't mix and match. There is no data on how effective or safe that combination will be. So when you do receive the vaccine, it will be very important for you to remember which product you receive so that you can get that same product for your second dose. Some other things we know from the data that's been reviewed so far is, as I mentioned, the studies did include various subpopulations. And so based on that, the CDC has a few recommendations. So for all of the special groups that are listed on the slide, essentially, it is considered safe or recommended to receive the vaccine. So if you have any underlying medical conditions, such as diabetes, hypertension, high cholesterol, or any other condition, if you're immunocompromised or have HIV, if you have an autoimmune condition like rheumatoid arthritis, if you're pregnant, if you're breastfeeding, if you have a history of Guillain-Barré syndrome or a history of Bell's palsy, based on the data that's available, even though it may be limited, it is still recommended for these populations as the benefits greatly outweigh the potential risk of the vaccines. So if you do belong to any of these special populations, you may have some concerns about, is it safe for me? But based on what we know, it is recommended that you still consider receiving the vaccine. For children and adolescents, as I mentioned, it is not yet authorized in those groups. So for Moderna, 18 years and over only. For Pfizer, 16 years and older only. So here's a summary of some of the facts. As we mentioned, the vaccine will help your body fight off the virus. The vaccines are effective. The vaccines are safe. And there will be different vaccines that are available. Even with the vaccine, you still have to practice your COVID-19 precautions. We still have to wear masks. We still have to practice physical distancing. We still have to wash our hands. And again, because we don't know how well the vaccine prevents the spread. So the vaccine, we know, only protects you. We don't know how well it protects other people. And for that reason, we have to still continue our typical COVID-19 precautions. And we have to keep continuing that also until the majority of individuals receive the vaccine. So when we talk about returning to normal, it really will depend on how quickly we can get the vast majority of Americans vaccinated with the vaccine. The faster we can do that, the faster we can return to normal. I already mentioned a bunch of this. And the last thing I want to highlight is that it does take 2 weeks for the vaccine to become fully effective after your second dose. So one of the problem or misconceptions that we're seeing is that people get the first dose of the vaccine and then they start engaging in risky behaviors. Oh, I got my first dose. Let me go hang out with my friends and family again. That's not the case. It takes 2 weeks for after the second dose to get full protection and full benefit from the vaccine. So you still have to take precautions in the time being so that you don't potentially become sick with COVID-19. And we are starting to see that there are people who received the first dose and who then subsequently got COVID-19 because they were exposed by engaging in other risky behavior, thinking that they were immediately immune, but they are not. And the final topic I want to cover is vaccine allocation. So you might have questions about, well, I want the vaccine, how can I get it? So let's talk about what that strategy and timeline looks like. So as a big picture, the federal government purchased several 100 million doses of the vaccine, and they are responsible for distributing it to the states. So the federal government decides how many doses to send to California, how many doses to send to Texas, how many doses to send to New York, et cetera. And then when the state receives it, the state distributes it to the local region. So then California decides, how many do we send to LA County? How many do we send to Orange County? How many do we send to Bay Area? How many do we send to Inland Empire? And then from there, the local county decides who gets the vaccine and how it's distributed. And so that's kind of what we're looking at for the big picture. In terms of when people can access the vaccine, it is going to be a phased allocation. For the very initial months, we don't have that much supply because the manufacturers still have to produce the vaccines. They still have to distribute the vaccine. So the very beginning, or what we call phase 1, there's limited doses that are available. And as we increase the number of doses that are available, we enter phase 2 and phase 3. So one of the things that we have to think about is, well, everybody needs to be vaccinated, but we only have a limited amount available for a certain number of people. So then the state has to now decide, well, who do we prioritize? Who should get the vaccine first? Who are the people who are at the highest risk of getting the disease? Who are the people who are at the highest risk of dying if they get the vaccine? And how do we ensure that there is fair and equitable distribution of the vaccine? These are all very difficult questions to answer that have a lot of ethical and real implications on people's lives, right? But this is the plan that the state of California has decided to go with, and that many other states in the United States have also decided to go with, using this phased allocation approach. So here's what that looks like. In phase 1, there are 2 main populations that are being prioritized with the limited supply: healthcare personnel and residents of long-term care facilities or nursing homes. Those are the population and individuals who are receiving the COVID-19 vaccine right now in what we're calling phase 1A. Within phase 1A, there are also sub-prioritization tiers, meaning not everybody who is a healthcare worker can get the vaccine right away. It's broken down into different tiers. Tier 1 were those individuals working in hospitals. Tier 2 is essentially those working in outpatient clinics. And tier 3 is everyone else who is a healthcare worker, such as your dentist, laboratory workers, and pharmacists, and your COVID-19 testing staff. So you can see here, based on the tiers, the thought process really was, who is the highest risk? And that answer was those who work in hospitals, because they're taking care of the COVID patients. And especially now with the surge, there's huge issues with the number of infections that are being seen in hospital settings. So phase 1A, hospital workers and long-term care facilities or nursing home, which is essentially our elderly who reside in those facilities. And they were chosen because throughout the pandemic, we saw that there were high rates of mortality in nursing home populations and high rates of transmission of the COVID-19 vaccine. Where we are in California right now, we are only in tier 2, phase 1A. And so we have not yet completed phase 1A just yet. Now, talking about what are the other phases, phase 1B, when we get to phase 1B, is going to be our elderly older adults who are greater than 75 years of age, in addition to certain frontline essential workers. So those frontline essential workers include first responders, education workers like teachers, people who work in food and agriculture like the grocery store workers, people who work in manufacturing, people who work in prisons, our postal service workers, people who work on the public transportation buses, etc. And so you see here that they decided that these were the frontline workers who are out there exposed on a day-to-day basis, and that they should be prioritized in phase 1B. Then in phase 1C, we have adults who are greater than 65. We also have any adult who is considered high risk. So potentially any adult who has diabetes, who has asthma, etc., will also be included in phase 1C, along with other frontline essential workers. So this now includes the rest of the critical infrastructure workers that are out there working on a daily basis. The state is still discussing and still approving these phases. We've only approved up to phase 1B so far. Phase 1C is still being discussed and is almost going to be approved. Phase 2 and phase 3 has not yet been identified. It has not yet been discussed, but phase 2 is expected to be the general population. So that is expected to be when everyone else will be able to receive the vaccine. So as you think about what phase I fall into, it will have to do with two primary things. What is your line of occupation and level of exposure? And what is your age or health status? Those are the main things that will determine how quickly you will be able to receive the COVID-19 vaccine using this phased prioritized distribution process. This calendar was just to summarize when the Pfizer and Moderna vaccines were distributed. So you can see here, it occurred mid-December, and that's what I was talking about. You know, it was released just before Christmas. It was released just before New Year's. And so having those holidays where a lot of workers were off really delayed our start of the COVID-19 vaccine administration. But now that we're past that, we should see an incremental increase in the number of vaccines that are administered throughout the state of California. And so we officially began administering vaccines on December 15th in California, beginning with our healthcare workers. And that has been proceeding ever since then. With the work that we're doing at the USC School of Pharmacy, we are working with the City of Los Angeles and Mayor Garcetti, and we have opened a closed vaccine pod throughout the county. There are 18 locations located throughout Los Angeles County to help us vaccinate healthcare workers. The more quickly we can complete phase 1A, the more quickly we can begin phase 1B and to beginning to offer the vaccine to non-healthcare workers and to elderly population. And so that is the work that we're doing now with the City of Los Angeles to provide access to the COVID-19 vaccine. And this is a general timeline of when most people can expect to receive the vaccine. This is just a proposal, right? The timeline is not defined. So there's nowhere that says we're gonna do phase 1B in February, we're gonna do phase 1C in March. It will depend on a number of factors. How quickly we can get delivery of the vaccine from the federal government, how quickly we can vaccinate more people in those phases. So the more people who accept it, the more people who get vaccinated, the more quickly we can move through other phases to give access to everyone else who wants to receive the vaccine. But the general timeline is that the general public may not expect to receive the vaccine until as early as March, but more realistically, probably the summer months of May, June, and July. So with that, I did receive the vaccine. So I myself also received the vaccine. So I am very confident in the vaccine safety and the vaccine efficacy. And I hope that if you have any doubts or questions, I helped alleviate some of that. And I myself received the vaccine. I actually got my second dose today. So with that, that's all the information that I have, and I'll be happy to open it up for questions.
Well, thank you so much, Dr. Dang. That was very informative. We do have a few questions in the chat box, and you have answered some of them. So I don't know if you would like to take a look and see if you would like to actually avoid some overlap.
Yes.
Yeah, sure. Dean Papadopoulos, do you want to come in?
No, there is one question, and I think what I do, I think if you see, I put a reply straight. I don't know if I replied to everybody. It was a question about some nanoparticles, aluminum nanoparticles. Everyone, let me send it to everyone, the reply. So there is no aluminum nanoparticles in the vaccine. So I put the composition, is published, is not a secret. Let me see. So the nanoparticles that are formed, I don't know if you got it, that are formed, they are because there is a combination of the RNA with lipids, like cholesterol, like phosphorylcholine, and some other lipids, and acetic acid. Really, there is this form mini particles that can really penetrate and deliver, go through the membrane, and deliver into the cell the RNA. So there is no aluminum, no risk about brain damage, any of those things that in the literature exist for some of metal that form nanoparticles. So yes, and the information from Moderna directly.
And I would also add that there are no aluminum particles, like Dean Papadopoulos said. There are no preservatives. there's no latex, there's no virus, and there's no antibiotics in these vaccines.
I'm looking through the questions.
So 90, maybe I will repeat the questions, and then maybe Richard, you can 94.1 efficacy. What does that mean for the rest 5.9%? Did they contact the virus by accident? Did they get sick? Light, severe?
Yes, so there were some individuals in the treatment group that did end up getting COVID-19. The vast majority of them were symptomatic, right? So they either had a fever, they had loss of taste or smell, chills, fatigue, whatever it might be. There were I believe there were 0 hospitalizations and deaths though, as a result of the vaccine. So in terms of vaccine efficacy, that's what that was looking at. So 94.1 vaccine efficacy, they were able to prevent symptomatic disease. The rest of that population then did develop some sort of symptoms. So maybe their immune system wasn't strong enough, or the vaccine didn't work for them. They were exposed somehow, and then they eventually did develop symptoms of COVID-19.
And actually, this brings to the next question. Efficacy was determined by how many people caught the virus, but do we know that those who received the vaccine were exposed to the virus and still did not get COVID? We don't know. This type of experiments actually, are ethically cannot be made. So although there is a movement in England, volunteers even, to be exposed to the virus and to see the efficacy of the vaccine, but not in the United States from what I know. So no, we don't know, but from the statistics, from how many people really exposed from the population, and that from those, how many they got vaccinated, that they were infected, and some who they were not vaccinated. This is the only way. And Richard, anything else?
No, that's it.
So since CDC dictates that COVID positive patient is off quarantine after 10 days, does this imply that the natural immunity protects transmission?
Yeah, so I think the big question is, if I've had COVID before, do I still need to get the vaccine, right? And so there's some information about that. So it is thought that if you've had COVID-19 and you've recovered, that you should have innate immunity for at least 90 days or 3 months. Now, next question is, do I need to still receive the vaccine? So the CDC says that if you want to get the vaccine, you still can. However, they do recommend that you consider waiting because we have limited supply, and they would prefer that you save those doses for somebody else who needs it, because you should have immunity for 3 months based on your recovery of the disease.
Correct. Next, is there a potential problem for the mRNA entering the cytoplasm of various tissue cells besides the muscle cells? Essentially, mRNA-mediated immunity utilizes our own cells to produce S protein. Would recombinant made spike protein be a better option? Would it probably be more expensive due to purification? So actually, there is a history there. There have been 20 years trying to make vaccines against the S protein. S1 protein existed on the SARS-1 virus, if you remember, in 1990 in Toronto. So, and they tried for 10 years to make vaccines. Also, the Mediterranean MERS virus, it was also a coronavirus with an S protein similar that failed to make. Again, technology keeps evolving and they may succeed. Today, actually, the information as of 2 days ago, there are 63 vaccines in clinical trials and 85 under development. And some of them are against S1 protein. We don't know yet if they will be successful. Is it more expensive? Absolutely much more expensive. And not only that, if, for example, you like to make one against a mutated protein, you have to start from scratch. So we don't know always when you deal with mutations, like we talked about recently, the news mutated, COVID-19 virus. If it is to remake a vaccine from scratch with the protein, it will be extremely more expensive. So currently, some doctors are advocating that available vaccine supplies are best used by providing one injection to a maximum number of people rather than using 2 injections for a smaller number of people. Your opinion, Richard?
Yeah, so that's been discussed a lot over the last few days, and the FDA yesterday came out with a statement that it is not recommended, and they discourage the 1-dose strategy, the half-dose strategy, and even just looking at the data, the trials did not look at the efficacy after 1 dose. They only looked at it after 2 doses. So we really don't know how effective the vaccine is after one dose. It could be 1%, it could be 94%. We just don't have that information. And so based on that lack of data, I think it would be unsafe to give everyone only one dose in an effort to try to maximize the number of people who receive the vaccine.
So what percentage of the population has to be vaccinated before we can relax the COVID precautions? As we said in the beginning, the exact number is not known, but CDC suggests between 50 to 70%. What is the time frame between first dose and second dose?
That's a great question. And the first dose and second dose timeframe will depend on which product you receive. So if you receive the Pfizer vaccine, it is a 3-week timeframe. And if you receive the Moderna vaccine, it's a 4-week timeframe.
And there is another great question. What is the risk if you have 2-3 groups within the same family? What needs to be done? I mean, you mean 2-3 people within the same family. So in United States, actually, up to now, it is only the family member who works as a healthcare worker that gets vaccinated, which is not true in some other countries. But in the United States today, they vaccinate only the individual. I don't know if this will change, but Richard?
Yeah, there's discussions about that, whether we want to consider family pods, and I don't think that's been decided yet. But in the time being, what I would recommend is that even though you received the vaccine, again, you still need to continue the same precautions of wearing masks, limiting your activity, limiting your exposure. And that's especially the case if you're living with other people in your household who may be high risk that you don't want to expose.
Is it safe for women planning to get pregnant in the next few years to get the vaccine? Do we have any idea if the vaccine could affect fertility?
Yeah, that's a great question that there is limited data on. However, based on the science of the vaccine product, the recommendation is that it is thought to be safe for women who are either pregnant or planning to be pregnant, and that there are no current fertility concerns. And some of the things that lead to that is that the mRNA, I think Dean Papadopoulos said at the beginning, is a very fragile fragment. It has a very short half-life, so it doesn't stay in your body for a very long period of time. So the chances of the mRNA transferring through the placenta to the fetus is unlikely due to the degradation of that product.
So I think actually, to my opinion, and again, I work in fertility, part of my work, so there is more debate whether COVID-19 being infected affects fertility. And there is a lot of studies actually ongoing to assess, because we don't know. Now we have the first generation, I can say generation of patients has been now 6-7 months. Patients that come off the ICU unit, of the treatments, and the studies going to see whether fertility is affected. And there is, some cases, but we don't know if it is because of hospitalization, because of cofactors, or what is the real. But I will not really think this will be a problem. So it is important to emphasize the need for precautions after both first and second dose. Actually, this is a comment. You see it, Richard?
Yeah, I mean, I agree with the comment, absolutely. Even after the second dose, you still need to continue the COVID precautions, and that will likely continue for several more months after we complete vaccination with everybody.
I cannot believe we answered all the questions.
I think, yes, we did. Thank you so much. Thank you so much for your time, your expertise, for joining us tonight. And I hope we will be able to get vaccinated, all of us, soon, and go back to our normal lives. Again, thank you so much, Dean Papadopoulos, Dr. Dang. And I hope we'll see you, the rest of the community members who have joined us today. We'll see you soon in another of our events. Thank you.
Thank you. Very nice meeting you all.
Thank you, everyone.
Good night or Kalinichta.
Thank you. Thank you so much.
Thank you.